Welcome to a presentation on Alzheimer's disease. Here's a case about Beth, who has classic symptoms and onset of Alzheimer's dementia. Let's discuss the drugs in the next few slides and then decide what the options are for her treatment. Alzheimer's disease is a devastating illness with progressive memory loss and impaired thinking. As the disease progresses, neuropsychiatric symptoms may develop, and the person is unable to perform routine tasks of daily living. Alzheimer's disease affects more than 5 million Americans and is the 6th leading cause of death in the United States. Early effects are seen in the hippocampus when the patient experiences memory loss. Later, the disease progresses to the cerebral cortex, where speech, perception, reasoning, and other higher functions are affected. The brain actually decreases in size. There is a reduced cholinergic transmission. The levels of acetylcholine can be 90% below normal. Acetylcholine is an important neurotransmitter that is critical in memory formation. The goal of Alzheimer's disease treatment is to improve symptoms and reverse cognitive decline. Currently available drugs cannot do this, so our attainable goal is to maintain the patient's independence for as long as possible. Drugs now in use may slow loss of memory and cognition and prolong independent function. The 4 common drugs to treat Alzheimer's disease may slow loss of memory and cognition and prolong independent function. However, for many patients, even these modest goals are elusive. The respective mechanisms of action differ between the 2 classes of drugs, which allows the drugs to be combined for potentially greater benefits. Both drug classes work by altering the balance of neurotransmitters, which is disrupted due to neuronal damage. Treatment of Alzheimer's disease with these drugs can yield improvement that is statistically significant but clinically marginal. I love the analogy given that taking these drugs is equivalent to taking a weight loss drug and losing half a pound after 6 months of therapy. It is not recommended that all patients receive these drugs because of their modest benefits. Cholinesterase inhibitors may delay or slow progression of disease but will not stop it. Drugs that block cholinergic receptors, for example, first-generation antihistamines, tricyclic antidepressants, and conventional antipsychotics, can reduce an individual's response to cholinesterase inhibitors. Pharmacologic treatment with cholinesterase inhibitors may decrease risk of death. Although a minority of individuals will benefit from a noticeable improvement in memory, the majority of responders will achieve only a relative plateau in disease-related symptoms for about 1 to 2 years. Of the 3 approved cholinesterase inhibitors, oral donepezil and transdermal rivastigmine are FDA approved for mild to severe Alzheimer's disease. Oral rivastigmine and oral galantamine are approved for mild to moderate Alzheimer's disease. All cholinesterase inhibitors should be started at the lowest possible dose and titrated gradually. This is particularly relevant in older patients who are more sensitive to cholinergic adverse effects, and in those whose comorbidity may be exacerbated by altered acetylcholine metabolism. Cholinesterase inhibitors should not be stopped abruptly, as patients may experience rebound worsening of cognition. Consider tapering and discontinuing these drugs in advanced disease. Memantine, an NMDA antagonist, is indicated in moderate to severe Alzheimer's disease. It is well tolerated and modestly improves symptoms. Co-administration of memantine with a cholinesterase inhibitor may be considered as the range of Alzheimer's disease symptoms increases and the severity of behavioral and psychological symptoms worsen. Memantine can be given as a sole treatment if cholinesterase inhibitors have not been tolerated and/or have been shown to be ineffective. Now we are going to talk about additional medications that may be used to help with symptomology and behavioral problems associated with Alzheimer's disease. Depression may affect 25% of Alzheimer's patients. It is associated with wandering, agitation, and aggression. Evidence of antidepressant benefit for depression is conflicting in dementia, perhaps due to differences among studies. Experts support trying them for depressed mood in dementia patients. Antidepressants are relatively well tolerated compared to antipsychotics. Citalopram is effective for agitation and reducing caregiver distress, but also can cause QT prolongation and worsen cognition. Citalopram may also be effective as risperidone for behavioral and psychotic symptoms. Sertraline may also improve behavior and functioning and reduce caregiver stress. Atypical antipsychotics are indicated for agitation or psychoses that is severe, significantly distressing to the patient, or causes the patient to act in any way that creates a danger to themselves or others. Aripiprazole, risperidone, and olanzapine have the best evidence of efficacy. Reserve haloperidol for emergency situations such as acute delirium. Benefits are small at best. Benzodiazepines are among. Okay, what to do with Beth? What is the main goal of therapy for a patient being treated for Alzheimer's disease? Well, we would like to do A and B, but the best answer is C. We can somewhat treat the patient's symptoms and reverse the cognitive decline, but as the disease evolves, these goals are not attainable. We can only prolong independence as long as possible. Which of the following medications are specifically approved for the treatment of mild to moderate forms of Alzheimer's disease? The only option without memantine is D. Memantine is for moderate to severe Alzheimer's disease. What would you prescribe for Beth? You could prescribe any of the 3 cholinesterase inhibitors. I usually use donepezil and begin at a low dose, which is 5 milligrams per day, and increase to 10 milligrams per day in 4 to 6 weeks if needed. Again, benefits usually only last 1 to 2 years, if seen at all. And then as the disease progresses, memantine can be added. This is such a sad disease. It takes a toll on the caregiver, too. I often see the caregiver die before the Alzheimer's disease patient. Thank you for your time and attention. I hope you have learned something about Alzheimer's disease.